Hello and welcome to DDW-TV. I'm Courtney Jasmine. Day one of Digestive Disease Week 2021 is in the books, but there is still so much ahead for this incredible event. Tune in to the ASGE Presidential Plenary, #StickItToCovid, advancing endoscopic practice during the COVID-19 pandemic. Also, don't miss the SSAT Doris and John L. Cameron guest oration, Teamwork, Patient Experience, and the Future of Healthcare. Plus, make sure to explore over 2,000 e-posters and full-text abstracts where you can interact with presenters via chat and see all of the latest GI innovations, access special offers, and discuss your specific needs with trusted industry partners in the new Industry Supporter Showcase. Over 75 industry supporters are present from the pharmaceutical, device and instrumentation, nutrition, internet, and software sectors. Interact and connect with industry supporters via chat, meetings, and one-on-one video scheduling. See even more from these industry supporters in the DDW Theater by attending product theaters, 45-minute pre-recorded sessions about the latest GI products and services. These sessions do not offer CME credit, but they are a valuable chance to keep up to date with the latest technology in the field. DDW Highlights is a new offering at this year's DDW. As an additional resource to access DDW content, it provides a high-level overview of some of the best science from the meeting. With more on DDW Highlights is Sales Director of International Business Development at Infomedica, Marlies Jagersma.
So the Highlights program aims to offer an overview of the DDW conference. From all the information available at the conference, it offers a selection of topics and packages them in an easy-to-digest format. We call them MED files, and they're designed to provide medical education on the go, so you can get the flavor of a conference presentation in just a few minutes. A really nice feature is that some of the MED files will also have an expert commentary alongside, designed to offer a feel of some of the conversations you probably might have had with colleagues over a coffee after a session, for example. With that, we try to create some discussion points and adding a little context to that particular summary. For example, how a new drug or technique might fit into current practice and considering points of interest or areas that need more study. On top of that, we will also have a bonus item in the form of posters. Each poster will have digested key messages, author podcast, and some handy downloadable slides. Well, the highlights are a new offering this year, and they are intended as an additional resource to supplement the best of the DDW virtual sessions. And as we all know, the medical conferences are fast, and DDW brings together 4 sponsoring societies and a huge number of experts and topics. Even in a virtual setup, there is limited time to access all the content and the attendees might be interested in. So sometimes it's easy to overlook a session based upon the title, or maybe because it's happening at the same time as something else you are logging onto, or you simply forget to come back to the on-demand content. With the highlights we're offering, we have watched a selection of those presentations for you. And the added bonus as an attendee is that if you're interested in what you read in the MED file, you can always log back into the full DDW site to watch the original presentation. They will be available on demand for 90 days post-meeting within the virtual platform. Yes, absolutely. The conference highlights program is designed in the spirit of sharing data with a wide global audience. So we want to help disseminate important findings and foster the best practice for researchers, clinicians around the world. So you don't need to have been an attendee at the meeting. The DDW conference highlights are entirely free and open access. So just come and visit ddwhighlights.com for quick and easy access, and you can find a selection of what was offered at the actual meeting. I hope that people get a good sense of the variety of topics offered. DDW covers the fields of gastroenterology, hepatology, endoscopy, and gastrointestinal surgery. We have tried to pick a good balance of presentations from each of those areas, and we hope that there will be something for everyone, from researchers and academics to our colleagues in the clinical practice. Maybe it will give you the tools you need to change something in your practice, or perhaps just a few anecdotal data points or ideas to debate with your colleagues. It's just a high-level overview of some of the best science from the meeting. Well, actually, the team is still working with Dr. Friedman, who is the editor of the program, on the content at the moment. But I can tell you that we'll have something for each of the key fields I just mentioned. And we've shortlisted some sessions looking at surgery and malignancy. We'll cover therapies currently being investigated in the big disease areas like Crohn's disease, inflammatory bowel disease, irritable bowel syndrome, but also rare diagnosis. Of course, we will be covering some sessions around the impact of COVID-19, and we'll look at how technology is shaping things, from the impact of social media to the use of virtual reality as a treatment modality. Well, a final element, I think, is that Dr. Lawrence Friedman will share his personal overview. So in addition to the med files, the expert commentaries, posters, he will actually be presenting the findings from his top 5 studies. So this additional webinar will showcase his own personal favorites and takeaways. The program will be active for a year, so we will be launching just a few days after the meeting. So once you can actually already sign up at DDW.highlights.com, and you can be notified when the highlights are actually available. It's easy. It's free. You just go to the URL just said, ddwhighlights.com, or you can go to medfile.com. Registration is easy and straightforward. You can have instant access once you've signed up. And by going through that channel, we really hope you will enjoy the opportunity. So thank you. Take care of yourself and the people around you.
AI isn't coming. It's already here. The future is now. The GI Genius Intelligent Endoscopy Module uses AI to automatically detect polyps of all shapes and sizes. Trials with GI Genius demonstrated a 14% absolute increase in ADR compared to high definition alone. This transformative solution seamlessly integrates with your workflow so you get the results you need in real time. Detect the undetected, powered by AI.
The COVID-19 pandemic resulted in a litany of health concerns unrelated to the virus itself. With job loss, social distancing, and other traumatic lifestyle changes, one such health concern is the rise in alcohol consumption. To discuss the rise and its impact in treating patients with alcoholic liver disease is AASLD President Dr. Raymond Chung.
Thank you for the question. There's really been major collateral damage from the pandemic. We have seen since March of 2020 at our institution and colleagues at other institutions have witnessed alarming rises in hospitalizations, intensive care unit transfers, and even deaths. They're about 30 to 50% levels higher than those seen in preceding years. And this is truly an alarming trend, superimposed, I might add, on an already alarming trend in hospitalizations that has been in place over the last several years, in fact, the last decade or plus. And this is particularly, I think, evident in certain groups of patients, including those who are very young, particularly those in the age groups between 25 and 45, presenting with severe versions of acute alcohol-related hepatitis. So the alcoholic liver disease can take on many forms, including acute alcoholic hepatitis, but also exacerbation of those with pre-existing chronic liver disease, or even those with cirrhosis. And I think that we can all readily imagine that the increasing isolation, stress, financial stress, joblessness, depression, anxiety, and even boredom have all contributed to this picture of increased consumption of alcohol, or in some cases, resumed consumption of alcohol for those who perhaps had been off for some time. And I think this has been compounded further by limited access of these individuals to care during the pandemic, and perhaps has contributed to the severity of those patients as they present to the hospital. So early detection and attention to these issues may be missed, again, owing to the conditions and constraints that the pandemic has imposed on us. Um, I think it should also be noted further, I think, exacerbating this problem already, is that patients with alcohol-associated cirrhosis or chronic liver disease are themselves at increased risk for adverse or poor outcomes should they contract COVID-19. So that COVID-19 related outcomes in patients with these conditions are really considerably worse. So this has really been a dramatic problem for all of us managing alcohol-associated medical complications, particularly liver disease. I think we're going to need to take great care in terms of our limited contacts with patients during routine care, to be much more vigilant about their behaviors and habits and their choices. And I think we should take that time during those encounters, whether they be live or virtual, to ask our patients to take the extra step of inventorying what kinds of behaviors, social and consumption behaviors, they may be engaged in. This could be the use of a simple alcohol questionnaire, like the audit questionnaires, for instance, that many practices are used to doing, or simply just a direct interrogation of those patients to ask, I mean, how are you doing, and what are you doing to cope with the pandemic, and are you consuming more alcohol or other substances? And I think these are extraordinarily important questions to ask. I think the other area where we can exercise more vigilance during this time is really getting those patients to do screens for evidence of liver injury. Liver tests can certainly be an early indicator of uh, complications related to ongoing use of alcohol, particularly heavier use of alcohol. So I think that perhaps there's just no substitute for enhanced vigilance for this group of patients. Yeah, we've solved the science of hepatitis C insofar as the development of wondrous cures in the form of direct-acting antiviral therapy is concerned. But if we're going to meet the goals, the ambitious goals that have been laid down by the World Health Organization and other bodies in terms of achieving elimination by the year 2030, that is to say, to reduce incident HCV infection by 90% and attributable mortality by 2/3, we're going to need to identify the epidemic where it is. And in this country, as is true worldwide, we haven't come close to identifying the epidemic. In the U.S., screening strategies have really only identified 50% of those who are thought to be chronically infected with hepatitis C. So the other 50% are really going to have to be identified. And so one and perhaps the initial effort and measure that has been engaged has really been to change our screening recommendations. And this exists in the form of one-time screening of all adults. Formerly, it had been those born between 1945 and 1965, or baby boomers. Now we're being asked, and the recommendation has been endorsed by the U.S. Preventive Services Task Force, to screen all adults between the years of 18 and 79 to be screened at least once for hepatitis C, and in those who are engaging in ongoing risk factors, to be regularly screened for hepatitis C. But I think we're going to need more than just than simple recognition of cases. We're going to need to link those cases to care. Because if one looks at the cascade of care from those who are chronically infected all the way down to those being identified, treated, and cured, we're going to need to find a way to take those identified cases and link them to care. And there are still cracks that those patients can easily fall through once identified and before getting plugged into to really curative care. And so one strategy I think that really has yet to be turbocharged, and it really needs to be, is the idea of really testing and treating individuals, particularly in areas where the risk of transmission is very high, such as those patients engaged in active injection drug use, for instance. And these patients might be encountered, for instance, in clinics like opioid substitution therapy clinics, where that use is prevalent. And I think it is in those locales that we're going to need to identify a means of rapid point of care testing with results available immediately, and a linkage to treatment, which would be available on the spot for those patients for whom we are concerned about spotty attendance or adherence, to get them the care they need. We're increasingly seeing that simplification of treatment is possible, trials indicating that we can potentially give patients the entire supply of a curative regimen of direct-acting antivirals and get them through that course of therapy without need of monitoring visits into a successful outcome with high rates of cure, has been shown in studies to be possible. And this is true not just in this country, but also in low and middle income countries around the world, where hepatitis C also resides in high frequency. We're also going to need to couple HCV treatment, i.e. treatment of the medical complications of substance use, to care for the substance use disorder that so often spawns the contraction of hepatitis C in the first place. And so this kind of joint integration of care is going to be essential in terms of really reducing the underlying basis for which the behaviors were engaged that contracted hepatitis C. So substance use disorder clinics, I think, would be critical to integrate with medical therapy, and of course to engage as well in harm reduction measures like syringe exchange programs as an example. Treatment of active injection drug use should not be viewed as a bar or barrier, insofar as it has been clearly demonstrated that this group of patients can be treated successfully using directly observed therapy or even patient navigators as examples of ways to get them through that treatment episode. And then decentralizing care so that it's not just, it doesn't reside only in cities or in areas with high densities of specialists, but really to again, allow caregivers and to train caregivers to be able to treat these patients where they exist, which is often in rural locales, and to train through video conferencing or other tools the providers in those locales in the art and science of the treatment and cure of hepatitis C. So this will involve necessarily enlisting primary cares, advanced practice providers like NPs and PAs, nurses and community health workers, who can all quite successfully engage in the identification and treatment of this group of patients. And I think it's this combination of strategies that will allow us to really get to effective elimination and to meet the goals that have been laid forth by the World Health Organization.
With moderate to severe ulcerative colitis or Crohn's disease, your plans can change at any time. Your head wants to do one thing, but your gut says, not today. GI-focused Entyvio is made for this. Entyvio acts specifically in the GI tract to prevent an excess of white blood cells from entering and causing damaging inflammation. Entyvio has helped many patients achieve long-term relief and remission. It may help you too. Infusion and serious allergic reactions can happen during or after treatment. Entyvio may increase risk of infection, which can be serious. Although unlikely, a risk of PML, a rare, serious, potentially fatal brain infection, cannot be ruled out. Tell your doctor if you have an infection, experience frequent infections, or have flu-like symptoms or sores. Liver problems can occur with Entyvio. If other treatments haven't worked well enough, ask your doctor about Entyvio. If you're experiencing financial hardship during these trying times, Takeda may be able to help.
Cook Medical's EcoTip Insight device continues our tradition of innovative devices that support your mission to deliver exceptional patient care. EcoTip Insight bridges the practices of EUS and hepatology for direct measurement of portal pressure for a better understanding of liver health. To learn more about this exciting new frontier in endohepatology, join Dr. Jennifer Kolb of the University of California, Irvine on Saturday at 5:30 p.m. Eastern.
Digestive Disease Week turned 52 years old, but that's not its only impressive statistic. So here's DDW by the numbers. Last year, DDW had over 14,000 attendees from every continent on Earth other than Antarctica. 63% of attendees came from North America, with the remaining 37% international. 103 countries were represented by physicians, researchers, nurses, and students. 71% of attendees have prescribing capability and are represented by 17 different tracks. Over 600 scheduled events are taking place over these 3 days, with over 2,000 e-posters on display. But maybe most impressive of all is that DDW manages to grow bigger and better every single year. The American Gastroenterological Association is the trusted voice of the GI community, and that voice is spoken by a new president as of this year. To discuss his plans for the AGA is President Dr. John Inadomi.
Oh gosh, it's got to be all the fame and the fortune, exotic travel, invited lectureships, sports cars. And then COVID came along. And there was no travel, there was no visiting professorships, and even DDW was online. I even found out that Hashem's Maserati wasn't from the AGA. So then I had to think about values and culture. And what I find is that the AGA is my organization, mainly because I share the same values. And I've been really enjoyed working with the folks in the AGA, the committees. I was the chair of the Clinical Practice Committee and the Quality Measures Committee. I felt that was a great way to add my voice to the conversation. I was also part of AGA Council, which is the arm of the organization where there's implementation of the educational priorities of the AGA, such as DDW programming, advocacy for our field of gastroenterology and hepatology. We're the only PAC for our specialty. Mentorship. I've been involved in the academic skills workshop, both as a faculty and as a director. And our journals. I've been an associate editor for gastroenterology, where we like to disseminate what we feel is the best science in our field. I think overall, I feel like I can contribute to the field of gastroenterology beyond my roles at the university and beyond my day job. And I think we have a louder voice through the AGA because we, the members, represent the entirety of our field. And we have the best vision for what gastroenterology and hepatology needs to become in the future. And that's why I really wanted to join the AGA, and particularly this leadership position. Well, for three, I would say the AGA has a multiple year strategy. So it isn't a single president establishing strategy. I think it's really important. It's not about me, it's about you. And I think that there are several aspects. First is we are committed to advancing the practice of gastroenterology and hepatology and helping our members understand the transition to the future of medicine as we evolve, with changes in reimbursement and sites of practice, and even methods of care delivery. We are instrumental in facilitating research and innovation through our young investigators, especially the Research Scholar Awards and the Academic Skills Workshop I had mentioned earlier. We provide education and training, specifically through Digestive Disease Week and the Crohn's and Colitis Congress with the Crohn's and Colitis Foundation. And advocacy for our field. I feel like we can advocate for our profession and our patients through addressing issues and advising Congress through our PAC. We certainly disseminate science through our journals, and we have many: gastroenterology, CGH, CMGH, TIGE, and the new gastroenterologist. And I think the last part, which is really important, is increasing the equity, diversity, and inclusion. And I'm really proud to be part of the AGA Equity Project. It's a comprehensive, multi-year program to address the barriers to otherwise creating a diverse and inclusive organization, not just the AGA, but our entire field. And the AGA, of course, supports this, as well as our multi-society group supporting equity, diversity, and inclusion. The second major part that I really want to focus on, and I think it starts with Dave Lieberman in his focus in colorectal cancer screening, my interest, and then the two presidents behind me. It's John Carruthers and Barbara Hume. All of us are focused on reducing mortality from colorectal cancer. And I think that we've had some early wins. We had, now it looks like the loophole where a screening colonoscopy turns into a diagnostic if you find polyps. That language is being addressed at the level of Congress. So that's exciting. I think that the next step in creating a program, really a national colorectal cancer screening program, will be to ensure that colonoscopy co-insurance doesn't occur anywhere in that continuum, whether it be the primary screening modality or there's another screening modality that leads to colonoscopy or even surveillance. So that whole colon cancer screening continuum has to be addressed in terms of no co-insurance for patients, and make sure it's a right of all people within the United States to be able to have colon cancer screening. That's a major issue. And finally, linked to that is adherence. We know that a third of people who are appropriate for colon cancer screening do not undergo screening. And to try to address those barriers through education, through different interventions, through access, those are the kinds of things that I really feel are important and something I can do as part of my presidency. Oh, definitely. In-person travel. I mean, Zoom like this allows for good content, I would say, but not substance or innovation. My best ideas for research have always come through interactions with my peers and colleagues and friends, just like in Digestive Disease Week. And those are kind of things that I really miss, that interaction, not just the social aspects, but the scientific aspects that occur when we're together and spontaneous. So I think that's the most important thing I'm looking forward to in the next year. Oh, certainly you'll get me at the plenary, the presidential plenary, also the clinical science plenary. And as a prior chair of the clinical practice section of AGA Council, certainly I'll be at the clinical practice sections and sessions, as well as a clinical practitioner zone. So I hope to see you there as well.
AI isn't coming. It's already here. The future is now. The GI Genius Intelligent Endoscopy Module uses AI to automatically detect polyps of all shapes and sizes. Trials with GI Genius demonstrated a 14% absolute increase in ADR compared to high definition alone. This transformative solution seamlessly integrates with your workflow, so you get the results you need in real time. Detect the undetected, powered by AI.
At Cook Medical, we are dedicated to bringing you groundbreaking devices to help you deliver exceptional patient care. Our spirit of innovation continues with devices like HemoSpray, Flourish, our next generation Instinct Plus clip, and the new EcoTip Insight. Through physician collaboration and thoughtful design, we create simple solutions for complex medical problems, and it is our privilege to partner with you to improve patient care.
The American Society for Gastrointestinal Endoscopy's Executive Planning Committee brings some of the most engaging programming related to endoscopy education at DDW. With more on ASGE's programming is Secretary and Member Executive of the Committee of the Governing Board, Dr. Brett Peterson.
Well, hello. I'm happy to have an opportunity to visit with you this afternoon. I'm currently in my third and final year as Secretary of the ASGE, and the major component of that role is coordination of the ASGE's contributions to DDW. So welcome and a hearty invitation and encouragement to attend in a virtual fashion this year's DDW 2021, which will be held virtually on Friday, Saturday, and Sunday, May 21 through 23. So thanks for the opportunity to visit. Despite the fact that this is a virtual meeting, the major components of DDW are retained and being presented by the four societies. By the ASGE, we're particularly excited about the presidential plenary session, which this year will be divided in two with 90-minute sessions on Saturday morning and again early Saturday afternoon. The morning session will be following a relatively traditional format with outstanding abstract presentations intermixed with state-of-the-art presentations by Dr. Asma Shaukat on colonoscopy quality, by Dr. Thomas Roche from Hamburg on advances in EUS, and by Mr. Tom Lowry of Microsoft on the rapidly advancing field of AI in medicine. The afternoon session will be a bit different than frequently seen in prior years, beginning with a panel discussion and presentation on healthcare reform involving John Allen, former president of the AGA, Mr. Michael Chernow, and Klaus Mergener, our current president. The other components of the afternoon will be sessions on ergonomics, diversity, and a panel discussion involving both fellows, trainees, and faculty members on training in the pandemic era. Other sessions that we're quite excited about that have evolved from prior years are a series of international symposia developed together with national societies from India, Canada, Australia, Mexico, Japan, South America, International Committee, and Europe. And these will all be focused on broad but advancing areas in gastroenterology, and I think will be quite key to the program. As every year, there are many excellent abstract topic fora, and this year with the virtual environment, many of them have been mixed up a bit with shorter abstract presentations, greater opportunity for podium presentations by abstract submitters, and numerous state-of-the-art talks, panels, and discussions. Clinical symposia, as usual, will include both advanced topics for the academician or the focused specialty practitioner, as well as general topics for the clinician. So we're quite excited about what can be done even in this environment. Well, planning for a virtual meeting is actually a little more difficult than planning for a traditional face-to-face meeting. It's a shorter meeting. It's been changed in time of the week and hours of the day, but there's a lot of logistics that go into planning for all the virtual recordings and presentations, coordination of times across continents and nationally. And some components that are traditionally part of DDW for our society, the ASGE, have been moved in time. The annual postgraduate course will be held in late April this year on a weekend away from DDW. Train the Trainer programming, Meet the Professor programming, Breakfast with Champions are other components that will not be held this year, and some of them will be moved to other sessions in June or later in the year. So what is retained are all the core key elements related to academics and education for the clinician. Well, we anticipate there will be resurgent interest in a face-to-face meeting come 2022. The annual meeting next year will be in San Diego, a particularly attractive venue. And as travel and group meetings become safe to pursue, we're quite eager to see a resurgent attendance. There will be continued use of virtual components to the meeting, I'm sure, and part of that's given that we've all gained great facility with these modalities, and it enables attendance by those who can't leave their practice, can't leave their home for one reason or another, and for those overseas. So it expands our audience internationally to wider groups than could otherwise attend a face-to-face meeting. In the longer term, with recognition of what works virtually and what works as face-to-face, there may be further evolution, possibly to a smaller meeting, possibly to different time frames. This year, we're experimenting with Friday, Saturday, Sunday, and that might be an attractive time frame as opposed to the traditional Saturday to Tuesday meeting for many who are in practice and pulling out of practice for one or more days. So smaller meetings may also allow us to investigate other locations from an urban standpoint around the country. So we'll see what happens after this year's meeting, and that will probably influence future planning. Well, as with most aspects of life, there have been major changes this year. I think we've actually developed new skill sets and new capabilities for virtual programming and distribution of outstanding programming from afar to all those who've been interested, both nationally and internationally. We've improved our curriculum and are working towards a more cohesive and anticipated regular curriculum in the coming year, much of which will be virtual and will be retained as weekly and monthly meetings. Future courses may be elected to be virtual versus face-to-face, depending on their nature and content. But of course, we're eager to get back to face-to-face meetings, particularly for those hands-on components of many of the courses held at our training center in Chicago. This past year, we've hired a new CEO who comes with great experience with both virtual programming and with a variety of other things we're hoping to expand into. GI Leap, our repository of online programming and training and educational offerings, has grown tremendously this year and is by default has had to become more organized and more coordinated. And I think that's showing up already in its use and its capabilities. So there are quite a few things that we've done well with this virtual environment. Financially, we've managed to do well with a combination of rigorous cost cutting and retention of all staff, with major adaptations by staff and volunteers, retaining our productivity and developing new programming. So we're excited to get back to face-to-face and the ability to interact. And we've actually matured and grown as an organization in the process. And I think the future is bright.
Success in the field of GI is a collaborative effort. The Society for Surgery of the Alimentary Tract is a leader in outreach to other organizations to make research breakthroughs and better serve patients. To discuss how teamwork makes the dream work is SSAT President Dr. Mark Callery.
Well, thanks for having me. First of all, I hope this is going to be a very successful virtual Congress. And we had all of these auspicious goals for building collaborations as we entered last year's DDW, which was canceled. So we've had even more time to think about this and have actually executed in a number of realms that we'll talk about. I'm a big believer in the concept of horizontal leadership, horizontal collaboration. And by that I'm talking about creating a fabric of unity that everybody can land upon and grow together upon. It's much more possible in today's world, the way we live with electronics, etc. But there are great opportunities, I think, to do it in a way that's going to drive how GI medicine, and specifically in our case, how GI surgery occurs. This can be in everything along the lines of clinical expertise and innovation, through to academic leadership and scholarship, through to education, absolutely for sure, and then, frankly, through to governance and leadership in the delivery of the specific types of specialty interests that people have. There are so many ways to collaborate, some of which are old and many of which are hopefully going to move tomorrow. And I'll talk about this in the President's address of Creating Tomorrow Together. Certainly our findings from speaking with our members is that the best opportunity to leverage at DDW is having so much multidisciplinary expertise available. We'd like to work harder with our sister DDW societies, much as we have with our sister GI and general surgical societies, to foster more collaborative and unified approaches to these four types of areas of governance, scholarship, etc. One example of this is a combined clinical symposia that I know Dr. House, our program chair, will give you more detail on, but it comes on the concept of creating the team of teams. And I'm delighted to let you know that our orator for the Cameron oration is Dr. Connor Delaney from Cleveland Clinic in Florida, who's really a thought leader in this concept, especially in GI medicine. Conceived, built, and directed the Digestive Disease Institute service line at Cleveland Clinic in Cleveland before moving down to Florida. And he'll be with us, and I'm sure that everybody attending DDW will learn a lot by participating in that. But that's just one indication. Our program chairs are going to get together ahead of the meeting, I'm told, with a webinar to discuss what to expect as the best offerings coming forward. That's a new collaborative concept. We're doing this with our sister societies. We've actually updated and changed the governance structure of our board of trustees and are going to be incorporating and naming in new members from our other societies, such as SAGES, the AHPBA, the American Society of Colorectal Surgeons, others, into actual board seats at our board of trustees level of leadership. Getting everyone's idea and creating a collaborative project is pretty much a must-win opportunity. Well, great question. Pretty much all of GI medicine, whether it's benign disease like inflammatory bowel disease or malignancies such as colorectal or pancreatic cancer, pivots on this concept of multidisciplinary team management. Everyone is involved to see the patient, but then perhaps as importantly, to structure a care path that gets navigated down as a team approach from decision to implementation. I think most agree that it has really had clinical dividends for patients. There's been improvements in some disease managements that cannot be denied. And because you bring in endoscopy, surgical, medical side of all GI diseases with what is DDW by driving more multidisciplinary educational teaching and learning formats at the DDW Congress. That's what people, I think, are going to resonate to. That requires the collaboration we talked about earlier. There are also ways to build upon the strengths of the individual societies to create patient advocacy information, physician APP advocacy information to facilitate multidisciplinary care paths. There are economic rewards by cutting costs, reducing waste. It's just really the way to go nowadays. It's not the same as it was when I was younger, but with younger people coming through now, it's the standard of care pretty much. So we hope to see a lot of that more with everything we're doing at the SSAT. Certainly as we build our interactions in the surgical realms, it's a standard approach now, both inside and outside of America. Well, this we thought may have been a consequence of, the world is flat concept with the drivers of connectivity worldwide, but it may have been one of those rare consequences that are good of what the pandemic has forced upon us. Frankly, it became a worthwhile, actionable effort to drive collaborative interactions and structure them with our GI surgical colleagues who are members and not at different locations in the world at this point. We could only do so much to build and collaborate here at home because of everything. So we reached out, and it has been really a fantastic endeavor. We do not actually resemble the SSAT in terms of international global outreach compared to what we did 2 years ago. Just some examples would be our international combined clinical symposia webinar series, all clinical-based management, where you get professors from the two main areas of the webinar, America, with the strength that North American surgeons provide. And then in one case, we had one recently with Japan on gastric cancer. It was unbelievably important, very high end. And in the chat, we were getting questions from Nairobi, from Ethiopia, from Vietnam, from Peru, from Europe. It was really something else, about 750 attendants. And it reached a lot of people just by an international outreach. Of course, a real crown for the SSAT is the development and inauguration of our first international chapter, Mexico, which creates 5.6% of our membership. And from this now formal international chapter in Mexico, we have the model upon which to build further outreach chapters. I know that this is going to be structured in a very deliberate strategy by our incoming president, Dr. Nick Vote. And it's going to add, beyond structure, some new concepts, even to the point of humanitarian outreach at a global level. So a lot to look forward to, a lot to be proud of, and a lot of fun's been had. We all have to reemerge. That's a given. And that's not just the SSAT, that's pretty much every element of life, and certainly academic and clinical societies. So that's going to be the same for DDW and our societies. The good news for the SSAT, however, is that we do not need to reinvent ourselves or remodel ourselves. We were already underway with executing on a carefully developed 5+ year strategic plan that had been built in 2018 and were well underway. At that time, that strategic plan addressed what we diligently described as being those challenges going forward, typically to increase member value and engagement, very important. Another was to develop a organizational framework for sustainability and growth. And then very much importantly was a strategy to deepen and build our role for leadership in GI and all of surgery, and to execute upon that as well. Some of the things we've talked about in terms of certainly the collaborative endeavors we've been part of have indicated that we've been moving well in these realms. We're going to continue to do that as we emerge from the restraints of the pandemic. We are going to be steadfast in our ability to do everything we do in our already well-established umbrella of diversity, equity, and inclusion. We're going to work to drive member value, especially for the younger, newer members of the SSAT, and hopefully become more and more of a collaborative must-have society for DDW.
The landscape of acid-related GI treatments has been largely unchanged for decades. That's why at Fathom Pharmaceuticals, we're exploring a novel mechanism of action for both H. pylori and erosive esophagitis through development programs built on studies of 8,000 plus patients around the world. Discover our passion for changing the landscape in GI.
Running since 1969, this week marks the 52nd Digestive Disease Week. With such a rich history, every returning attendee is sure to have a favorite DDW memory.
It's hard because obviously so many of the DDWs carry a lot of personality from the city that you participate in. But I probably, so far, my first one that I would go to is Chicago in 2017. It was the first DDW that I went to as an attending. And it was just a really incredible feeling to finally be board certified in a true part of the field. And as I started to contemplate my role within the field, the possibilities were endless, and having a lot of terrific mentors and role models there to help model different career paths was something that I'll never forget.
Wow. There's so many great memories from DDW. It's hard to single one out. I have to say probably my favorite DDW memory was when the first time a postdoc from my laboratory gave a talk at DDW. And it was just a great moment of pride for me to see my trainee stepping up onto that international stage.
Well, most of my favorite DDW memories have to do with the people. There was a very fun time a couple years ago in one of the DC DDWs where I partnered with two patient advocates who do a lot of work for the patients with inflammatory bowel disease, that community. And we went to a lot of each other's networking opportunities and also sessions. And they did a takeover of the Duke GI Twitter account, which I normally manage. And it was just fun to go outside your area, work with patient advocates and not just the scientists, researchers, fellow physicians. And it was also a lot of fun to have someone else run the Twitter feed for a little bit, because it's always a little frantic for me. I'm doing my own learning and I'm trying to capture everything that Duke GI is doing. And so it was very nice to be able to just sit back for a bit and let them do some of the live tweeting and reporting. And I also was part of a video that they made for their blog. So that's one of my favorite. But, you know, I've been going to DDW since at least 1999. So there's a lot of memories.
I think one of the best things about DDW is getting to see my colleagues from all around the world, around the country, and being able to, you know, share our latest findings with one another and just catch up.
I think my favorite DDW memory, I have so many, right? I have so many favorite DDW memories. I'm always looking forward to the random oh my gosh, I haven't seen you in forever kind of meetups in the stairwell, or in a plenary session when you run into somebody you haven't seen in a long time. So there's always these serendipitous reconnections. But I think the other one specific memory I would say is, I remember when Twitter was going live, when social media, Twitter was just getting underway, and it was our first foray into DDW, hashtag DDW meeting. And there was so much energy around trying to get our other colleagues on Twitter, trying to go to that back room where everybody was tweeting and having chats. And it was just a lot of fun trying to figure out how to do social media at a annual meeting together. I just remember that in particular because it was something I've never experienced before.
So my favorite memory is probably about 2 to 3 years ago. I think it was in Washington, D.C. at that time. And I was at the end of my internal medicine residency, and I went with a bunch of my co-residents to DDW. And just the experience of going through the convention hall itself, walking through the posters, seeing the exhibits, walking through the big inflatable colon. I think that afternoon was amazing because I had my peers with me and I could see everything laid out, and really it was a matter of time of what I was able to see. So that was really excellent. That one afternoon, I still remember very clearly, especially that big inflatable colon. It's very, very memorable.
It definitely has to do with going to the conferences in person to wonderful locations, like San Diego was the last time that I went. And just getting to roam around the city and the actual DDW area with other people that you are either training with there or that I knew from across the country that had gotten together for the conference. So it's just a nice place to mingle and see everyone that you don't always get to see.
Yeah, my favorite DDW related memory is probably when we were having really good discussions in San Diego, for example, for really long time, and often these discussions went into dinners in the evening, and then next day early in the morning we met again, and we continued the discussions regardless how less we slept. And the level of science and energy in the conference was really inspiring, and I still kind of feeling that inspiration.
I think my favorite DDW memory is actually going to San Francisco and meeting some of my colleagues on Twitter, because I've only been on Twitter for the last couple of years, and it was the first DDW where I walked in there and I'm meeting all these people that I've been in touch on Twitter in person, and people stopping me in the corridors and taking photos, and it was really amazing experience meeting people in person after having been in touch with on Twitter, and even co-authoring some of the papers, having never met them in real life. So that's San Francisco was a real a highlight.
Dr. Carl V. Crawford, Assistant Professor of Medicine and Attending Physician at the New York Presbyterian Weill Cornell Medical Center in the Division of Gastroenterology and Hepatology, was with us yesterday to discuss the role of the gut microbiome with regard to C. difficile infection. Dr. Crawford returns now to talk about the burden of C. difficile infection and recurrent C. difficile infection.
So there's many kinds of patients. Both initial C. difficile infections and recurrent CDI can affect a wide range of patients and cause a significant health burden. So although antibiotics are considered the standard of care for the treatment of CDI, they are also a major risk factor for its development. Other major risk factors are older age, a weakened immune system, having other comorbidities, and being in a hospital or a long-term care facility. However, and also surprisingly, even healthy individuals who have not had any antibiotic exposure can develop CDI. For many physicians and for us as gastroenterologists, our patients with inflammatory bowel disease are more likely to get CDI, and they may even experience more severe symptoms than patients with IBD alone or CDI alone. So overall, patients will differ in age, sex, duration of infection, and the source of their infection. C. difficile infection was declared an urgent public health threat in 2013, but it didn't happen overnight. In the late 1970s, C. difficile emerged as an important pathogen following the introduction of broad-spectrum antibiotics. In the early 2000s, an increase in severe cases of CDI was noted in Canada, the United States, and Europe, which was attributed to the emergence of an epidemic type of C. difficile. It's this hypervirulent NAP1B1.027 strain that emerged in North America and Europe. In 2010, C. difficile emerged as the leading hospital-onset healthcare facility-related infection, eclipsing MRSA, or methicillin-resistant Staphylococcus aureus. In 2013, the United States Centers for Disease Control and Prevention, or the CDC, identified CDI as an urgent public health threat, and it continues to be an urgent threat even now. As the most common healthcare-associated infection in the United States hospitals, CDI affects approximately 500,000 people annually. Approximately 2/3, 68% or so, of CDI cases are healthcare-related, and the rate of healthcare-associated gastrointestinal infections caused by CDI is only growing. Recurrent CDI significantly increases patient burden, both physically and psychologically. An observational cross-sectional study involving 350 participants with a self-reported CDI diagnosis was conducted through an online self-administered survey. A large majority of those patients indicated that CDI had a significant impact on their daily activities, and this included patients with active CDI, about 94% of them, and patients with a past CDI, as high as about 64.7% of those patients. In addition, the majority of patients who responded experienced physical and psychological consequences due to their C. difficile infection. Approximately half of the participants indicated that symptoms remained after the infection, and what was really disheartening was a loss of hope in that approximately 41% of those patients believed they would never get rid of post-CDI symptoms. C. difficile infection is also associated with significant comorbidities and a mortality rate as high as 6%. The 30-day mortality rate of CDI ranges from 5% to 14% after the initial episode. Of note, in a recent CDC research letter, the mortality rate was reported to be 44% among patients with COVID-19 co-infection, although we can only speculate as to what degree C. difficile infection contributed to this overall mortality. Results of a retrospective cohort study of a Medicare patient population indicated that sepsis occurred in 27% of cases, and 7% of cases required bowel surgery, including colectomy. A recent published retrospective analysis evaluated serious clinical complications, in particular sepsis and bowel surgery, in patients with CDI and recurrent CDI during a 12-month period following primary C. difficile infection. This study analyzed a large commercial healthcare claims database containing payment information for patients who received care in a variety of healthcare settings. Clinical complications were documented over 12 months of follow-up and stratified into 4 groups by the number of recurrent CDI episodes. So 0 recurrences, 1 recurrence, 2 recurrences, and 3 or more recurrences of CDI is one group. During the 12-month follow-up, sepsis occurred in 16.5%, 27.3%, 33.1%, and 43.3% of patients, and subtotal colectomy or diverting loop ileostomy was performed in 4.6%, 7.3%, 8.9%, and 10.5% of patients, respectively, for each of those increasingly recurrent CDI groups. So this study showed that as recurrent CDI increased, so did trends for higher rates of sepsis and bowel surgery. The study analysis also revealed that the higher the occurrence of recurrent CDI, the higher the healthcare resource utilization and total all-cause direct medical costs. So this is a lot of food for thought on complications for patients from a physical and psychological perspective, but also from a healthcare resource perspective too. Recurrent CDI significantly affects hospital quality metrics and reimbursement, and some of the numbers I'll mention are impressive. Data from a single referral center published in 2017 indicated that up to 85% of all patients with recurrent CDI were hospitalized within 12 months. In a study evaluating a Medicare population, it was reported that 37% of patients with recurrent CDI were hospitalized at least 3 separate times, and that hospitalizations averaged 18 days. A retrospective analysis of commercial claims data showed that emergency department visits averaged 4 per year for patients with CDI, with a gap of approximately $3,000 to $29,000 in reimbursement per patient. So overall, the total cost of a patient with recurrent CDI ranged from $131,000 to $207,000. Even in this day and age, there are limited options available for gut microbiome restoration, which aims to repopulate a diverse gut microbiota to treat disease, specifically recurrent C. difficile infection in this case. One historic approach has been fecal microbiota transplant, or FMT, although most studies assessing the benefits of FMT are retrospective case series or systematic reviews of contrasting sources of microbiota with limited safety data. In a meta-analysis published in 2019, it was demonstrated that the efficacy of FMT for CDI was much lower in randomized clinical trials than in observational studies. A previous meta-analysis described a primary cure rate of 89% with FMT, but no randomized controlled trials were included in that study. So the differences in the estimated effects of treatment between randomized controlled trials and observational studies may be due to application of strict inclusion and exclusion criteria in the control setting, which leads to inclusion of just a small proportion of patients from daily clinical practice, and that limits the generalizability of results. So to overcome this gap, what we really need is the availability of a safe, effective, and standardized FDA-approved microbiota-based therapeutic that is supported by randomized controlled trials and robust level 1 evidence that reflects the real-world population of patients who suffer through this unfortunate and vicious cycle of recurrent C. difficile infection.
Ferring Pharmaceuticals is leading the way in research of the microbiome. To discuss with me how they will shape the future of microbiome therapeutics development is Chief Scientific Officer Dr. James Tersey. Dr. Tersey, tell us a little bit about Ferring Pharmaceuticals.
Sure. So Ferring is a global pharmaceutical company that is committed really to helping people live better lives. We have over 6,500 employees in 56 countries, and we distribute our products in over 100 countries. Now, Ferring's been in existence for over 70 years. We're not only devoted to developing new therapeutics, but also expanding our product life cycles and expanding personalized healthcare solutions. Now, clearly, we have a focus on advancing microbiome research as a way to develop those innovative new ways to both treat and prevent disease.
Can you tell us more about Ferring's research in the field of microbiome therapeutics?
Well, the microbiome is a highly diverse microbial community, and we're recognizing that it plays an essential role in our health, all of our health. There's a growing body of evidence that shows that when there's disruption of that, whether it's disruption of the composition or loss of diversity of the gut microbiome, that there may be associated risks for very serious illnesses. Now, we at Ferring, what we're looking to do is really shed light on that link between disease and disruptions in the gut microbiome, with the idea of really exploring the potential for repopulating the diversity of the microbiome and really restoring hope to patients. Now, we're pioneering a new category of microbiome-based therapeutics. They're standardized for quality, safety, and we're starting with the treatment of recurrent C. difficile infection. Now, in addition, we've got a diverse pipeline of investigational drug products that are also being developed under our pioneering microbiota-based drug platform, so-called MRT drug platform. So there's potentially more to come.
I think you touched on it before, but can you explain why you're starting your microbiome-based research in recurrent C. difficile infection?
So C. diff infection has been named as a major and urgent public health threat by the US CDC, or the Centers for Disease Control and Prevention, and it affects nearly 500,000 people every year. But an important consideration is that C. diff infection recurs in up to 35% of cases within 8 weeks of the diagnosis. So 1/3 of patients are possible at risk of recurrence. After the first recurrence, it's estimated that up to 60%, almost 2/3, may develop a subsequent recurrence. So integral to solving the problem is restoring that healthy gut microbiome. And that's becoming increasingly accepted as a promising treatment for recurrent C. diff. Now, current therapeutic options there are a little bit limited and really lack the product standardization and administration methods, which has created a situation where a product like ours that would ideally be approved, regulated, safe, and effective is critically needed.
And lastly, Dr. Tersi, tell us about any investigational products you're developing.
Now, our first investigational product, called RBX2660 or 2660, that's currently in phase 3 development. Now, RBX2660, it's potentially a first-in-class microbiota-based live biotherapeutic. And what that's being studied to do is deliver a broad consortium of diverse microbes to reduce recurrent C. diff infection. RBX2660 has Fast Track designation, Orphan designation, and Breakthrough Therapy designations from the US FDA. And in the field of microbiome-based therapeutics, we believe that RBX2660 is the most advanced and has been exposed to the highest number of patients enrolled in prospective clinical trials. Now, we're excited to embark on a new course at Ferring as we aim to really transform the potential of microbiome restoration into these novel live biotherapeutics. And while we're starting with recurrent C. diff, we believe this is only the beginning of how we can harness the power of the microbiome to fight disease.
Thank you so much, Dr. Tersi. We appreciate your time today.
No, thank you very much.
More information about Ferring's commitment to microbiome research can be found at ferringusa.com. Viewers can also visit Ferring's dedicated microbiome Twitter channel at FerringMBiome.
Right now, millions of patients are suffering with GI disorders such as overt hepatic encephalopathy, irritable bowel syndrome, chronic idiopathic constipation, opioid-induced constipation, bowel preparation, and ulcerative colitis. At Salix, we have kept up with these unmet needs for more than 30 years by providing an industry-leading portfolio of high-quality products that address these conditions. Through our dedicated and innovative R&D team, we're also exploring potential new scientific breakthroughs. And we remain committed to important healthcare provider investments in education, charitable grants, and sponsorships. We will continue to invest millions of dollars in patient education and do our best to broaden access to Salix medications. Because our mission to improve the care for GI patients continues today. For us, there is no finish line.
DDW finishes strong tomorrow with the DDW Diversity Symposium, unique patient populations with GI diseases experiencing barriers to care. This session will challenge the surgeon and gastroenterologist's understanding of LGBT health concerns. Attendees will learn about cultural barriers to healthcare, ways to overcome them, as well as understand how to implement strategies to improve communication with diverse patient populations in everyday patient care. COVID-19 will also have a prominent place on the agenda with the AGA's COVID-19 and GI practice, learning from the past as we build towards a better future. and AASLD's COVID-19 and the liver essential updates for the GI and hepatologist. Don't forget to join the conversation through social media using hashtag DDW2021 and keep up with meeting news by visiting ddwnews.org. Thanks for watching DDW-TV. I'm Courtney Jasmine.